It's a research to practice series, May 28th, Advances in Early Detection of Lung Cancer with Dr. Akulian. We've got some more detailed information about Dr. Akulian, and then we'll go through some highlights here. Dr. Akulian, welcome. Really glad to have you here today.
Thank you for having me.
Absolutely. So he has his MD, MPH, and MBA, and works hard to mentor junior faculty locally and nationally after being the recipient himself of good mentorship during his career. And you can see mentorship is really a theme here. As we go to the next slide, he served as president of the Association of Interventional Pulmonary Program Directors. He chaired the American College of Chest Physicians Thoracic Oncology and Chest Procedures Network. Dr. Akulian completed an MBA during COVID-19 pandemic and served as frontline staff of the MICU. And finally, he has now graduated 9 interventional pulmonary fellows from the UNCIP fellowship. Outside of your professional bio, Dr. Akulian, what's something we should know?
Let's see. I'm the son of a winemaker, and have been actively engaged in that pursuit since I was about 7 years old. How about that?
That is great. That is great. I grew up out in Mendocino County and had to walk through grape vineyards every day coming home from school. So a lot of my friends in school, Fetzers and others with involved with winemaking. So that's near and dear to my heart as well. That's great. I had not known that. All right, let's go ahead and take our first poll everywhere question, always kind of a softball. Bronchoscopy is a technique used to look at your air passages with a small camera that's located at the end of a flexible tube. So while you're thinking about and then marking if that's true or false, we'll go ahead and put up our required disclosure slide. You've seen it. And let's give folks 15 seconds or so to, if you have not had a chance to respond. Robotic bronchoscopy is a technique that automates a procedure to look in your air passages with a small camera that is located at the end of a flexible tube. We're trending pretty heavily on true. Dr. Akulian, how are they doing?
They're doing real well. That's
Great.
Exactly what we do.
Okay. Well, we'll let you take it from here. Really glad to have you here and looking forward to the lecture.
All right. Well, thank you for the very kind introduction, and I'm happy to be here. Hopefully, we can have a little bit of fun with this and maybe shed some light on where things are going in the very near future, or even actively now. These are my disclosures. I'll wait for a heartbeat there and move on. So when we think about lung cancer, right, we think about staging patients, right, and we use these staging paradigms to really think about patients, not just prognosis, but how to communicate within a team framework, right? So how we can think about taking care of patients, what are the appropriate paradigms? And when we think about staging patients, right, we think about size of nodules or size of lesions. We think about number of lesions within a lobe or within multiple lobes. And we think about distant metastasis. But probably most importantly, or I might hazard to say, one of the most important aspects of staging is whether there's local regional metastasis to the lymph nodes. And so I always like to start any kind of bronchoscopy talk, particularly in the cancer space, just giving a nod to the idea that we need to stage patients appropriately during the procedure. And so looking at those lymph node beds to better understand their involvement or lack of involvement of the malignant process or suspected malignant process. So this is a sort of a stock image from a colleague of mine that shows a lymph node being pierced by a needle under ultrasound guidance. And that's via a bronchoscope called an endobronchial ultrasound scope. TBNA stands for transbronchial needle aspiration. So this is actually fairly old technology at this point, which shocks me when I say things like that. It's about 20 years old now. It was first introduced in about 2005 with one of the first studies being performed by Dr. Harith in Heidelberg, Germany, where they looked at over 500 patients with over 500 lymph nodes, and they biopsied a bunch of them to figure out exactly how effective this was. And what they showed was that there was a high sensitivity, specificity, and positive predictive value when using this technology. So they could not only find lymph nodes, they could accurately engage them, they could biopsy them with a needle effectively, and there were no complications. So this was an exciting time in the field of lung cancer care, and then it sort of reintroduced pulmonologists back into the field, which had been historically dominated by thoracic surgery, medical oncology, and radiation oncology. This was followed up pretty rapidly by Dr. Kazu Yasufuku, who's a thoracic surgeon at the University of Toronto. I think at this time he had just come over from Japan, where they actually looked at comparing EBIS, or this scope-based staging technology, to surgical staging, right, which is mediastinoscopy, where they make an incision above the breastbone and then put a camera into the chest and identify lymph nodes that are then biopsied in an effort to get an appropriate diagnosis. In this study, it was built as a crossover where patients would undergo EBIS followed by mediastinoscopy and vice versa. And what they found was there was high levels of concordance between EBIS and mediastinoscopy. But I think probably most interestingly, and probably the biggest takeaway from this study, was that these tools were actually synergistic rather than competitive, in that there were a cohort of patients within this study that were found to be non-diagnostic, or they didn't get an appropriate sample on EBIS, and subsequently on MEAD was found to have a diagnosis, and vice versa. And there were mediastinoscopy patients who did not have a diagnosis and then underwent EBIS and were found to have a diagnosis on EBIS. And so this is one of those things that, oftentimes people will try to pit one technology against another. But rather than doing that, I think we like to think of these as synergistic, where we potentially start with a more minimally invasive approach. And if that does not get us an answer, despite a high level of suspicion of involvement of these lymph nodes, then we turn to a surgical, more invasive approach. So I will move forward, and it looks like we've got another poll everywhere question. Right. It looks like we've got a couple more questions coming in, or a couple more answers coming in.
Yeah, I think that's good in the interests of time. How are they
Sounds
doing?
good. So they're doing real well. So this is absolutely true. This data comes from the National Lung Cancer Screening Trial, which completed its enrollment in about 2010, and was subsequently published not long after that, which showed that in patients who were considered high risk, and we'll talk a little bit about how we define those patients, if screened appropriately, were shown to have a decrease in lung cancer mortality by 20%. So very exciting data that really has pushed our practice dramatically. So we think about lung cancer, right? We think about lung cancer as being the #1 cause of cancer-related death, not in just North Carolina, not just North Carolina, but across the nation, right? And so, furthermore, when we think about lung cancer as an entity, it is far more lethal than the next 3 cancers combined. So that's been sort of a shocking statistic that I think is sort of underappreciated. That game changer was that National Lung Cancer Screening Trial, which showed that if you screen patients effectively, you can actually stage shift their initial diagnosis from a more advanced stage to an earlier stage. Historically, we've been finding about 65 to 70% of patients on their initial diagnosis were either in stage 3 or stage 4. With the appropriate screening paradigms, we hope to shift that downwards and shift the early detection higher. The reason why that's important is that that is directly associated with patient outcomes and mortality. That said, we have to be careful what we do, because when we look at who we're screening and how we're screening them, we know that the majority of what we find is not a cancer. And so we have to be really thoughtful about how we approach these patients and how we take them through the treatment or diagnostic pathway. In the National Lung Cancer Screening Trial, we saw that there were a number of positive tests. So the T0, T1, and T2, those were individual year time frames, where over the time they showed that lung cancer was confirmed in less than 5% of these patients over the course of having a positive test, right? And a positive test means having a nodule of some sort that was large enough to follow over time. And so again, the majority of the nodules found in this trial were not cancers. However, those that were found connoted this much improved lung cancer survival. When we think about confirming cancer, right? So the authors looked at how the patients underwent their various and sundry methods of diagnosis. Surgery was the lion's share of them, followed by bronchoscopy, then CT-guided needle biopsy, and then no invasive procedure at all. When you look at that complication rate, and this is one of the factors that sort of stood out, we saw that bronchoscopy had the least number of complications associated with it. However, as I'll describe later, until some recent technological advances, it was also one of the most challenged ways of obtaining a diagnosis. And we'll understand why that is later and some of the ways that we're overcoming that. Got another polar everywhere question for you here.
All right. So patients eligible for lung cancer screening should have which of these based on USP-STF criteria? A, at least a 20 PYH tobacco history. B, age 50 to 80 years old. C, actively or quit smoking in the past 15 years. Or D, all of the above.
And PYH means pack year history.
Good to know. I was not sure on that. All right, Dr. Akulian, how are they doing?
All right, doing pretty well. So it is all of the above, right? So this is part of the this is an extension of the NLST criteria, which was then taken up by the USPSTF, the United States Preventative Services Task Force, and trying to think about how we expand this care nationally, right? We have to think about who actually needs to be screened, where is the majority of disease, and how do we do this most effectively, both from a clinical perspective, but also from a cost perspective. So the initial task force recommendation was slightly off what NLST showed. NLST looked at 55 to 75 years old. The initial task force said 55 to 80, as there was subsequent data after NLST suggesting that the majority of disease lay within the older population. They initially maintained a 30 pack year history of smoking that was the same as the NLST, and we calculate pack years by number of packs per day times number of years that you smoked. So we know that that can potentially be a slippery slope in terms of a number. And then patients would either have to be actively smoking or had quit smoking within the last 15 years. This was subsequently updated to reflect a slightly younger age cohort, because there was some suggestion with some subsequent data that we would miss patients if we didn't drop the age a little bit. And certainly we recognize that a 30 pack year history, while not totally arbitrary, may underrepresent the overall cancer risk within the smoking cohort. These data or these recommendations are currently up for discussion with the NCCN, as well as CHEST and the American Lung Association, the American Cancer Association, all sort of weighing in. There's an active discussion happening around the idea of the smoke or quit smoking within the last 15 years, and just sort of say ever smoke, never smoke, right? So that any ever smoking patient would be included. There's also a conversation about removing pack year history, and rather just saying, again, did you ever smoke? Were you ever exposed primarily to, and when I say primarily, as the smoker, were you ever the smoker? And should you then be screened? And so there are data that suggest that we would improve our ability to catch patients if we adjusted some of these requirements downwards. When the USPSTF made their updates and their recommendations, it actually increased the number of people significantly who were eligible to be screened. It also increased the number of women versus men, as well as minorities. One of the major critiques of the NLST was that it was not really as representative of the overall population as one would hope, and that subsequent data was suggesting that patients were far sicker, and that there was a preponderance of disease or a higher level of disease within minority populations than what was seen in the study. And so part of the way to sort of pick at that was a change in some of the criteria by which one could screen. And I think that that's been effective, but potentially not as effective as it needs to be yet. So I think we're still finding that sweet spot as to who we need to screen and how often, and who gains the most benefit from it. Here at UNC, we've had a lung cancer screening program for a number of years. So Dr. Patricia Rivera, who has now moved on to the University of Rochester as the division chief of pulmonary and critical care there, actually started the lung cancer screening program with Louise Henderson, who's a PhD in the Department of Radiology. That program was started in about 2014, built on the shoulders of their work. Now in 2022, we've actually expanded the program into an early detection of lung cancer program that actually houses both the lung cancer screening program and an incidental pulmonary nodule management program. A dedicated nurse navigator was hired in 2022, and there are now monthly meetings that are held in a multi-T group. There's a weekly nodule board where we review lung cancer screening cases of concern, as well as incidental pulmonary nodules of concern. We're actively engaged in working on developing a dashboard to follow our outcomes, and we've streamlined some of the Epic user order sets and some of the different ways that we can ultimately track the data. So I think we've moved really in a great direction. Dr. Jason Long, who's one of our thoracic surgeons and a close colleague and friend of mine, is leading the lung cancer screening effort, and I'm currently tasked with leading the incidental pulmonary nodule piece of it. So I think we're moving in a really positive direction for the institution, but also, and probably most importantly, for the people of North Carolina. Again, thinking about where we've been and where we're at now, we've gone from just over 50 screening scans in 2014 to just under 1,400 in 2023. 2024 was even higher. It was sort of in the 15, almost 1,600 screening range. We've achieved Go-To Center of Excellence designation, and we are an Association of Radiologists Lung Cancer Screening Center. We've actively been discussing and working with the institution to now begin to develop active patient identification and tracking, right? So a lot of this is done retrospectively or in a reactive fashion, where a patient is found to have a nodule and then ultimately works their way through a pathway of referrals to get to the point of diagnosis or longitudinal follow-up. And for lung cancer screening, the patients have to be recognized to be eligible for screening and then enrolled appropriately. And so what we're actually working on doing is taking that from being a reactive process to being an active process, where we identify patients up front, and we identify nodules before they begin on that referral pathway. And we're trying to truncate the time it takes from their initial detection of either being a screening candidate or in having a pulmonary nodule. From that process, we're trying to shorten it so patients get to where they need to get to in a faster, more timely fashion. As we've started screening and as the ubiquity of CT scans has grown, our challenges have also changed, right? So we're now finding a situation where the large percentage of the nodules found are outside of the airway, so they're just sort of nestled within lung tissue. Many of them only have an intermediate or even low risk of pretest probability of cancer, meaning that based on patient characteristics and imaging characteristics, they don't have a super high, initial risk of cancer. The targets are much smaller, right? So we're now looking at targets less than 2 centimeters, less than 1 centimeter in many cases. And so this has really led the way towards some attempts at technologically overcoming some of these challenges. I'm going to give you a quick sort of historical rundown of where we were and why I said it was more challenging to get a bronchoscopic biopsy that was that was actually useful. And why, despite the fact we had low complication rates, we also probably had, or we actually had, we actually had low success rates as well compared to other modalities. So initially, conventional bronchoscopy, that's literally just putting a camera into somebody's airways and trying to drive by virtue of a CT scan that one has memorized lefts and rights based on, and then going out and taking a biopsy. As you can see, lesions that were less than 2 centimeters, we had less than a coin flip's likelihood of actually achieving a diagnosis in those patients. When we moved over 2 centimeters, again, we were only slightly better than a coin flip. And so, this was something that was a real challenge, and something that I suggest is a bit like going fishing in an ocean with no sonar and no ability to understand where the fish actually are. So this is old data, right? These are things that we don't really do much of anymore. I hope that people aren't doing much of. This was subsequently iterated upon with the development of a radial probe EBIS, right? So we talked about the EBIS scope that could look at lymph nodes. This was actually an ultrasound probe on the end of a long wire, so about the size of a grain of rice at the end of a long wire that would look around itself. And so what you're seeing here in the center of those images is the actual probe itself, that little circle, and it's looking around itself within the lung tissue. That sort of starburst pattern that you see, that's what ultrasound looks like within the lung, or within an air solid interface. So those little white sort of starbursts are literally ultrasound reverberations coming off the interface of a solid lesion and its relationship to the lung tissue surrounding the solid lesion. And so when we look at these images, we can see that there's heterogeneity in terms of the images that are created, and so interpreting some of these images can be quite challenging. But there have been attempts, and as you can see over there on the right hand side, when you have this sort of very sort of heterogeneous pattern, that those tend to be more malignant. There was a trial that was performed out of WashU where they actually looked back. They're one of the biggest users of radial EBIS, and they looked back at all their cases over about a 5-year span and broke them, substratified them down into different sizes. They then classified the radial EBIS view, so the image that was created as concentric, which is what you see here on the left-hand side, versus eccentric, right, which is the one there on the right. So again, the concentricity is basically is the probe completely surrounded by tumor or by target, and eccentric is it off to one side basically. And so they tried to figure out, how these things factored into their diagnostic ability. And what they found is when your probe is in the middle of the lesion, it makes a lot of sense. When you then put your needle in to where your probe was, you get a diagnosis about 84% of the time. When it's eccentric or off to one side, that becomes more of a coin flip. And there was a significant difference between those two, which makes a lot of sense. When they looked at things like using guide sheaths and some thin bronchoscopes and these sorts of things, they really found no difference. And so ultimately it became an issue or a question of, could you get to the lesion? Could you find it? Could you identify where you were? And could you get to the middle of it? And we didn't have a lot of ability to control a bunch of those pieces, which again led to significant challenges. Some of these challenges were ultimately were attempted to be overcome through navigation bronchoscopy technology. There were specifically, 2 main versions. There's a catheter-based version where you drive a tracked catheter out to your target based on a pre-procedural CT that creates a 3-dimensional construct of your lung and the target, and you're supposed to drive along the airways, and everything's supposed to line up perfectly, and you get a diagnosis 110% of the time. But we know that that's not true, and we know that this did not overcome all of the challenges, and we'll talk about one of the primary challenges that this was not able to overcome in a moment. And so, this technology, though, was sort of the next iteration of how we could get to these lesions and how we could potentially successfully biopsy them. When you look at the data, these are all single center data. They suggest that the diagnostic yield was now, approaching 80% on a regular basis. But as we know, single center retrospective data is fraught with error. Most often it's the fact that we're cherry picking those lesions that we think that we can get to more effectively, right? So these are not prospective randomized trials. These are not prospective observational trials. These are retrospective single center trials where somebody who was a clinician said, yep, I think I can get to that. They did that. They recorded it and they got a yes or a no. And so we know that we're stacking the deck, towards success, when in fact the real world may not reflect that as well. This was subsequently followed up by a study looking at a combination of both that radial ultrasound probe as well as the catheter-based technology, and it suggested that when you combine the two, you actually had an improved diagnostic yield. Interestingly, and this is a group in Germany, if you look at the ENB, which is the navigation bronchoscopy piece, their yield was around 59%. So again, maybe closer to reality as people were experiencing it than what some of the retrospective data that I just showed you might suggest, I should say. So the next phase of this was developing instruments that could be tracked and could be driven through ultra-thin bronchoscopes in an effort to think about, if we're great bronchoscopists, then perhaps we can drive there more effectively, and then we can use our tracked tools to line things up. These are some images of what this looked like. This is a lesion that we were biopsying here. You can see our little blue tool down the airway and into the lesion. This technology also incorporated an electromagnetic transthoracic approach, meaning sort of if you took a CT guided biopsy and you took a not real-time CT or a CT that had been done the same day and then lined it up, that you could push a needle that was tracked across the patient's chest wall and into the lesion to ultimately biopsy it. And so this is sort of, again, another attempt to overcome some of these challenges, in that if you have a lesion that's way out on the chest wall that is very difficult or almost impossible to navigate to, that potentially within the same setting, you could perform your EBUS to look at the lymph nodes. You could then try to navigate to it. If you couldn't navigate to it, you could biopsy it via the transthoracic approach. There was an initial pilot of this technology that looked really good, and the way it was built was patients underwent their nodal evaluation, followed by navigation, followed by transthoracic needle aspiration as appropriate. The nodule size was sort of nearing that area where we struggled for years, in that 2 centimeter range. When you looked at the combined yield of navigation plus transthoracic, it was 87%. When you added in the EBUS component, meaning we picked up disease in the lymph nodes that wasn't expected, it bumped up to 92%. Of the 24 patients who underwent the procedure, 5 had a pneumothorax, so roughly 20%-ish, but only 2 of them required a chest tube, so about 10%, which is really right in line with CT-guided biopsy data, suggesting about 20% of people get a pneumothorax and only about half of them require a chest tube to manage it. So when we looked at the sort of this final stuff of the non-diagnostic cases, they were melanoma and carcinoid. All of those non-diagnostic cases were diagnosed by video-assisted thoracoscopic surgery. Anything that was thought to be benign was either confirmed by surgery or followed for 6 months and showed either decrease or stability at 6 months, and showing a final yield, including the diagnosis or including the surgery, of non-diagnostic cases to be 100%. So we weren't leaving things on the table or with question marks. So that was really encouraging. It was followed by a prospective observational trial, multi-centered, 8 different centers. We were one of those centers, where we enrolled 160 patients, 160 completed the procedure. Of those, 156 got nodal evaluation. 6 of those were positive, so we stopped. We didn't go further. 150 actually got navigation bronchoscopy, and then 30 received the transthoracic approach. And when we looked at these data, things didn't look quite so good, right? So this is the difference between sort of prospectively looking at things, doing pilots, and looking at things retrospectively. When we look at the navigation bronchoscopy portion of this, it was about a 50% diagnostic yield. So again, a coin flip. When you looked at the transthoracic approach, it was less than a coin flip. So it was only a quarter of those patients that underwent the transthoracic approach received actual diagnosis, right? Whether this was a benign diagnosis or a malignant diagnosis, it didn't matter. Did they get a diagnosis or was it a non-diagnostic approach? When you paired everything together, we were just over 50%. So, one of these moments where, there's lies in statistics, right? So we look at the data, we think the data tells us one thing. When we begin to apply more rigorous trial designs, we begin to realize that maybe some of the data that we've developed or think is true may not be as accurate as we initially thought. And so, as they say, the struggle is real, right? So, this was a meta-analysis performed by Gerard Silvestri and Jessica Wang-Mully at MUSC down in South Carolina. And what they showed was, when we look at all of the data that's sort of out there, the meta-analysis would suggest that there's really not much difference in the overall diagnostic yield of these different approaches that were in existence. So VB is virtual bronchoscopy, meaning you're literally just following through sort of this virtual reconstruction of a CT. E&B is electromagnetic navigation. We just talked about that. Guide sheath is when you literally take a bronchoscope and run a little guide sheath through it that you can then put your tools. U is ultrathin bronchoscopy by itself. And then R is our radio EVIS is that EVIS probe that's the size of a grain of rice that I talked about. And so everything is sort of in that 70% range in terms of diagnostic yield. And while there's some significant differences among p-values, I think it's pretty widely agreed upon that the data would suggest that there's little or no difference in terms of these modalities. It would also suggest that we're using some of those data that might overinflate the actual efficacy of these. And so, at the end of the day, we like to say that 60% of the time it works every time. And so we're next going to say that, or ask a question, does CT guided biopsy of peripheral lung nodules remain better than bronchoscopy? All right, so pretty even split. Okay. Small numbers, changing the percentages significantly. All right, so maybe some of you are picking up what I'm putting down. And we'll see in the next few slides as to where we're headed and where we've been. So it seems like we got a 2/3, 1/3, where 2/3 are saying that know that maybe bronchoscopy is now entering an age where it will compete more effectively against CT guided biopsy. And we got about a third that say, nope, CT guided biopsy is still the way to go. So we've got 3 robotic systems that have been put onto the market in the last, so I'll say 3 to 5 years. And this is really where I think some advancement is being seen in the care of patients, particularly as we're seeing more and more what are suspected to be early stage cancers, right? So we have new tools that are potentially giving us new ability to benefit patients. And you ask yourself, what are some of the potential benefits of robotics, right? And so we think about control, we think about reach, we think about being able to reproduce things, we think about big data being created. We also think about, how much do these things cost? Are they actually better than the tools that we've been using for years and years and years? And where do they take us in terms of our practice? The 3 tools that are currently available, one is the intuitive ion. That's a shape sensing catheter, meaning it senses its shape in space, and that is relayed to a 3-dimensional model of the lungs that is ultimately overlaid onto the patient as you're driving through them. The outer diameter of that catheter is quite small. It's 3.5 millimeters with a working channel that is standard size, so we can actually fit normal size tools down there. They've, in the last 3 years, developed an integration with portable cone beam, allowing for near CT level images to be obtained during the procedure. The it's now J&J Monarch, because J&J bought Oris. It uses the same electromagnetic navigation software or technology that was used in previous setups. Only in this case, they have sort of this arm-in-arm robot where you have a docking arm that docks into a large airway, followed by a smaller arm that is then deployed. That's 4.2 millimeter outer diameter, and then can traverse multiple generations of airways out to this target that is generated. The NOAA Galaxy is a single-use catheter that also uses electromagnetics, as well as some augmented fluoroscopy or a tilt table with what's called digital tomosynthesis, which uses a C-arm or a standard fluoroscope to create a 360-degree reproduction of the lung and the chest, which is almost as good as, but slightly less than or less definitive than a cone beam CT. And so they have a proprietary technology that integrates the digital tomosynthesis to their robot. When we again think about sort of what this thing can do and what these robots can do, we think about reach. And so as we drive, this video here is showing a robot driving through the airway, and you can see it comes along, and then sort of right about there is sort of the natural limit of a regular bronchoscope. And you can see that this goes another 4 or 5 generations of airway while being able to see out into the periphery. Let's see if there's a fluoroscopic view or looking at how far out, right up against the ribs. So we can get the next little movie to play, maybe. There it is. So this is looking at control. This is the back of a dollar bill. And this is the camera looking with a needle pointing at the eye of the eagle on the back of the dollar bill. So again, being able to make microscopic adjustments in real time within the lung to reevaluate your relationship to the target lesion is quite useful. Some of the studies that have done to again look at this and quantify what these systems can actually do for us include the REACH study, which is performed with with the J&J robot. These are fluoroscopic images of a pig looking at where a standard bronchoscope would ultimately be able to reach, and then an overlay of where the Monarch J&J robot could put its catheter. So a significant difference between reach and where you can actually put these tools. In the Precision 1 study, which is a study that we performed with some of my colleagues at the Johns Hopkins, as well as UPenn and Memorial Sloan Kettering, we took 5 cadavers and performed 60 procedures after implanting 20 nodules in those cadavers. We defined where we put our needles based on our navigation and ultimately needle throws as central, peripheral, whether we pushed the needle all the way through the target, if we were adjacent to but missed it, and whether we full on missed it. And during this, we looked at robotics versus radioprobe EBUS versus electromagnetic bronchoscopy. So these procedures were all randomized within the cadaver as to which would go first. Each cadaver and each nodule target got all 3 of the approaches. And what we saw was, success of the nodule puncture was 80% for robotics, 45% for electromagnetics, and 25% for radioprobe EBUS with an ultra-thin bronchoscope. When we looked at miss distance, right, so how far was the needle from the actual target, we saw that there was significant differences across all 3 of the categories by ANOVA with a post hoc t-test, right? So we looked at to see if there was a difference among the 3, and then following that, we looked to see if there was a difference with each modality from each other. And there was a difference amongst all 3 of those, with robotics being the most, or having the smallest miss distance from the target. So when we think about our experience here, so we we obtained the robot here in about 2000 and late 2002, and we, in our first year we didn't have the integrated cone beam because it hadn't been developed yet, or it hadn't been released to the public yet. And in that first year, we saw that our robotic diagnostic success rate moved from 40% with just the standard navigation platform that we had been using to 76%. And so we were actually able to diagnose patients more effectively. And that was, I think, something that really, gave us a sense that this was a potentially game-changing technology that was going to shift the way that we were taking care of patients. That same meta-analysis that I pointed out earlier was recapitulated 10 years later by the same study team. In this case, though, they included robotics because robotics had since been included, and they made their total analysis more robust as there had been more studies developed. And what they showed there was that robotics seemed to have a signal towards improved diagnostic yield. Now, again, the numbers there are small, and this was a study that was published back in 2023, but whose data comes from sort of 2022 and earlier, right? So very early in the robotic adoption phase within the country, and certainly here at UNC. And so this was sort of one of those things where everybody said, we think that there's something there, and this data would suggest that maybe there was something there. When we think about our initial success rate, right, 76%, we think we could do better. And so this was, we ultimately did receive the integrated cone beam setup, and that's sort of that middle piece right there. And to the right, you see some of the images that we've actually been able to create. And so you see that far out into the periphery, we're able to now biopsy small lesions and actually, document that our needles and our tools are within those lesions. And so that suggested to us that we were improving our yield significantly. And when we actually looked at those numbers, we saw that we had. And we had moved from, the high 70s into the high 80% range in terms of our ability to diagnose small peripheral lung lesions. Going back to sort of why we had failed and why it's important that we have something like a CT, or some kind of perioperative imaging that's better than just fluoroscopy, is this idea of CT to body divergence. And so when these patients are getting ready for their procedure, they undergo a CT scan, a thinly cut CT scan. That's a full inspiratory breath hold. We know that none of us breathe at full inspiration with every breath. We breathe closer with something called functional residual capacity, which is kind of like down or near the bottom of our breath threshold. And so you can imagine that if we take your picture with your lungs fully inflated, and then perform your procedure breathing kind of more normally, as we might say, that nodule may not actually be in the same place that we think it is when we're actually driving out using that full inspiratory breath hold as our planning and navigation CT. When this was looked at, so in 2022, some of the folks at Mayo and the Cleveland Clinic, looked at this and they tried to understand what kind of divergence existed, between the CT and actual the case time. And what they showed was in the lower lobes, there was significant movement. So those cases with divergence, 73% of the cases had significant divergence, meaning that the target CT versus where the actual lesion was, there was either a 10% or less overlap, meaning those two things were pretty much either next to each other or far away from each other, but they were not overlapping one another. And the same was true when they looked at distance of diversion, so greater than a centimeter. About 82% of those in the lower lobes had significant divergence. And so this really highlights, one of the primary issues as to why for years we struggled with being able to actually biopsy small targets effectively, is they move around. And when they move around, they move throughout the respiratory cycle, and they move from the time that we get our planning CT to the time we're actually doing the procedure. The other big difference that hasn't yet been truly understood is that when we're breathing normally, we actually create a negative pressure in our chest, and we're doing negative pressure breathing. We suck air in. When we put patients on a ventilator for general anesthesia, we're actually giving positive pressure breathing. So we're pushing air into people. And there's probably differences in terms of how the lung actually moves through the respiratory cycle between positive and negative pressure. And there's some old physiologic papers that have looked at some of these things, but they've never been looked at from the perspective of targeting or specific, nodules or lesions that one might be trying to target. And so, so there's some work that needs to be done there, but I think this really highlights some of the challenges that are now being overcome with this real-time imaging that we're able to do that's integrated into our systems. Again, this is another image showing the type of divergence that can be seen in the lower lobes specifically. Upper lobes, less divergence, but lower lobes, there's a lot of movement, particularly because of the diaphragm's up and down motion. This is a set of images from a few of our colleagues nationally where they looked at the post-induction cone beam CT and the intra-procedure cone beam CT, and you can see all that gray that's occurring at the bottom of the CT image, and that's all atelectasis. That's all lung collapse. The bottom row of images was actually their attempt to apply some different pressurized breathing techniques. There still needs to be data associated or data developed around those approaches. But there's a suggestion that if we change the pressure volume curve dialed in onto the ventilator, that we can overcome some of this atelectasis and some of this divergence. This is a video of what that cone beam looks like. As it's, see if it'll work. Maybe. There it is. So this is a patient with a C-arm cone beam moving around them, creating the three-dimensional image. Takes all of about a minute. This was performed with a full inspiratory breath hold. Following this, these images are then pushed over to the navigation software, wherein we identify the distal end of our scope and then our target that has moved or changed. And once we do that, the machine picks up and decides that it can see the catheter, and it updates the target and moves the target so that we know where it is in real time. We can subsequently, push our tools across the target, and then ultimately repeat a spin to confirm that we are where we think we are, and then harvest as much tissue as possible for a diagnosis. So we know that with a cone beam CT that we get near real-time guidance. So we go from this position where that, we oftentimes will have an eccentric relationship to our target, and that through use of the cone beam, we can actually change the position of our bronchoscope and our tools, and we can actually place ourselves within the center of our target. And as I showed earlier from the old radio EBIS data, if we're in the center of our target, our diagnostic yield, enters the 80-90% range. There's been some publications. Again, this is a single center looking back at their experience using shape sensing robotics as well, in combination with cone beam. And what they've shown is that they have a diagnostic yield above 90% with high sensitivity specificity. This has, been pretty well recapitulated by a number of other single center and multi-center retrospective trials where they're showing high 80 to low 90% yield rates. And so, again, this is something that we've taken on and used pretty extensively, particularly as we're being asked to biopsy smaller and smaller nodules. Our threshold is typically right around 8 millimeters or greater, although at times we get asked to biopsy even smaller lesions. We've also started to think about how to pair this, or we've started to pair this with the surgical robotics. Surgical robotics has for years sort of struggled a little bit with small and deep nodules, subsolid nodules, and we started marking these lesions for our thoracic surgeons for them to ultimately resect. And you can see there a marked nodule that fluoresces under a specific type of fluorescent light. And then post-resection, you can see dye there looking at the actual nodule itself. We've recently submitted a publication looking at our first 70 plus patients with a propensity adjusted matched cohort. And what we're showing is that the nodule sizes that we are able to resect effectively after being marked is smaller than the unmarked ones. The distance from the pleura, or depth, right? So deeper nodules are also able to be effectively removed. And then subsolid lesions, so lesions that otherwise the surgeons struggle with identifying, are also able to be removed. Almost done here. And the real takeaway is that there's been no increase in conversion to open or conversion from robotics or bats to an open approach, right? And so what that would suggest is we're not only able to go after smaller, deeper subsolid lesions, but that there's no effect from a negative perspective on the surgeon's ability to complete their surgery effectively. Finally, the last couple of things to talk about, this sort of reflects back to the poll everywhere question that I asked. There was a recent trial that was published in the New England Journal of Medicine looking at image-guided navigation bronchoscopy versus transthoracic needle aspiration. It was a prospective randomized controlled trial, non-inferiority design. And what they showed here is, looking up at the top line, is accurate with 79 versus 73% diagnostic yield. And when you look down at the diagnostic yield, that was accuracy. When you look at diagnostic yield, 79 versus 77%. So no difference between the two when you were integrating this peri-procedural imaging piece of it. When you look at complications, however, significant differences in terms of complication rates, with transthoracic needle biopsy having significantly higher complication rates than bronchoscopy. So I would argue that the future is not so far away, and that we have a patient who shows up with a lung nodule. We perform a navigation bronchoscopy with a cone beam integration. We use a rapid on-site cytopathology team and or AI build. We're currently enrolling for a trial looking at an AI build to identify or to diagnose things at the bedside. And then following the confirmatory diagnosis of cancer, we deliver some kind of definitive treatment, whether it's ablation or some other type of therapy directly at the time of procedure. And so we're not quite there for those final two pieces, but I think we're somewhere in the next 5 years, and hopefully the next time I'm invited to come talk to you, I can talk to you a little bit about some of these next two pieces on this slide. So thank you for all that, and I think coming in right on time. I want to thank a lot of people who are involved in my career.
All right, Dr. Akulian, this is really exciting work. Thank you so much. Let's see, we're going to go to that question slide, and I'll be monitoring, and if we have some questions come in, we'll put those up. While we're waiting, this is really fascinating, and I'm wondering, are there other technologies as well? And I'm thinking specifically with the recent news cycle, there's a lot of information about fast MRI and dense breast tissue. Maybe we're going to see more fast MRI, machine access. Also, of course, it can't not ask about AI. What else is out there that may have an impact in terms of improving screening?
So I think in terms of screening, one of the areas that's sort of a hot area of research that hasn't quite yielded fruit is this idea of biomarkers or blood-based biomarkers or even nasal epithelial or airway biomarkers, wherein we're trying to risk stratify nodules that are found, or even detect nodules before the lung cancer screening CT. So there's a few companies that are also looking at exhaled breath condensates and trying to pick up certain chemical signatures that might suggest that there's a nodule or a cancer there before ever exposing patients to ionizing radiation. And so, these are technologies that are in their infancy and probably have another 5 to 10 years before they come to market in a meaningful way. But I think the future is bright. There's a lot of effort going into the space.
Great. And what I'm going to do in the interest of time is go ahead and advance the slides. And then we still have about 2 minutes left for somebody to get in a question. So if you have a question for Dr. Akulian, go ahead and submit that. We'll come back to this slide in just a moment. So I do want to say thank you. Thank you to the State of North Carolina University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, the team here at the UNC Lineberger Cancer Network, Lenny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Kimberly Riddick for all of their work. Thanks to Don Poe for the music. All right, I'm going to go back because we did just have a question come in. Let me pop that up. Okay. Thank you so much for this presentation. This may be its own topic, but how do you address the challenge with uninsured, underinsured for increasing the lung cancer screening and what resources do you have available for these patients?
Yeah, this is a huge challenge and something that I think is near and dear to all of our heart, and that we're trying to extend care as much as we can to the greater populace. Um, uh, this challenge is addressed through the standard routes that we try to address the uninsured and underinsured in the state of North Carolina. Lung cancer screening is well covered by insurance, so most folks who are quote unquote underinsured still would have their lung cancer screening CTs paid for. The uninsured group is a group that I think we all grapple with and struggle with, and certainly one that I don't know that we have good answers for. We are trying to develop resources around how we can make these things cost neutral or zero cost. We haven't quite achieved that yet, and so I think that's an area of significant interest in our group.
All right. Thank you to our audience for that question. There are no other questions, so let me see if we've got it. I think that does it.